Hello everybody. In this part of the heart, we'll talk about the conductive system of the heart, the mechanism of cardiac muscle contraction. We'll talk about the pacemaker potential, EKG and its events, abnormal heartbeats, regulation of heart rate and blood pressure. So this is the second part of the heart, or second lecture of the heart. First, we'll talk about the conductive system. Conductive system is formed by a highly specialized conductive tissue, and that system is responsible for the production or generation and transmission of the electrical impulse. Okay, so in the conductive system, you have the structures. Those are responsible for what? Production or generation and transmission of electrical impulse. Okay, so inside the heart, the electrical signal or impulse is produced in rhythmic way, one after another. Okay, so it is a network of highly specialized cardiac muscle cells. Now we'll see the parts of the conductive system. If you see inside the heart, in the right atrium, this is the right atrium, you know that. So inside the right atrium, you have two tiny nodes. Small round structures, those are the nodes. The upper one is located where the superior vena cava enters into the right atrium. So this is superior vena cava, the vein that brings the blood into the right atrium. Near the entrance of superior vena cava, you have the SA node or sinoatrial node, okay, which is also known as pacemaker of the heart. Many of you have heard pacemaker, so this is the pacemaker, okay. And in the lower part of the right atrium, where you have the, you must remember the right AV valves, in this area you have the atrioventricular or AV node. So these are two nodes in the conductive system, tiny round structures. And the nodes produce electrical impulse, okay, in rhythmic way, in rhythmic, like in regular interval, one after another. SA node is called the pacemaker because in normal heart, SA node is responsible for the heartbeat, normal heartbeat. Your normal heartbeat, if you know that the normal person's heartbeat or heart rate is 70 to 80 per minute, right? So this is controlled by the SA node. So SA node produces impulse at 70 to 80 per minute, 70 to 80 times per minute. And that is your heart rate, right? That's why SA node is called the pacemaker. AV node is slower, and normally it doesn't control the heartbeat. Its rate is much slower than the SA node, average 50, we can say 40 to 60 times or beats per minute. And normally this one doesn't control the heart rate, the SA node does. Okay. However, AV node is like a extra battery preserved or reserved. When SA node fails, if for some reason SA node becomes non-functional, then AV node starts to control the heart rate. But in that case, the heart rate will be slower, right? Because AV node cannot produce as fast as the SA node. So in that case, your heart rate will be 40 to 60 per minute. So these are two nodes, and they produce or generate the electrical impulse. Now, the signal from SA node is taken to the AV node by some fibers. These are called internodal fibers. Inter means in between the nodes, right? So these fibers are called the internodal fibers. You try to practice this picture, that will be helpful. Okay. So both nodes are located inside the right atrium. Then this is the interventricular septum. You remember the partition between two ventricles. This is left ventricle, this is right ventricle. So from AV node, a bundle of fibers, packed bundle of fibers arise and get into the upper part of the interventricular septum. And this bundle of fibers is called AV bundle because they arise from AV node, right? AV bundle. Because these fibers arise from the AV node. And then the AV bundle or bundle of His, it is also called bundle of His, it divides into right and left branches. Okay, so AV bundle or bundle of His divides into right and left bundle branches. So these two are bundle branches. How many? Two, right and left. And they move down through the interventricular septum. And then the right one enters into the wall of the right ventricle and branches like this. Okay. And left bundle branch also enters into the left ventricular wall and gives branches. These branches are called Purkinje fibers. P-U-R-K-I-N-J-E, Purkinje fibers. Makes sense? So these are the parts of the conductive system of the heart, and the signal that is produced in the SA node travels right all the way to the Purkinje fiber. And when the signal electrical, it is electrical signal, right? So when it travels, it spreads from SA node, spreads into to the wall of the atrium, and then from AV node goes down and spreads through the Purkinje fibers to the wall of the ventricles. When that electrical signal arrives in the heart chamber wall, that wall contracts, the muscle contracts. Make sense? So the contraction and heart rate are controlled by the conductive system. Force of contraction, how strongly the wall will contract or muscle will contract, and how many times, that's the heart rate. Okay, so now normally SA node produces 70 to 80 impulses per minute. However, if for some reason the SA node produces more, for example, if the SA node produces 130 impulses per minute, your heart rate will be 130. And that happens, right? When you get scared, your heart rate goes up. That means your SA node starts to produce the impulse faster. Okay, and when you are relaxed, resting, your heart rate goes down a little bit. That means the SA node produces impulse at slower rate. Okay, so you see those parts I already mentioned. So here you can see this is the SA node, AV node, both are located in the right atrium, internodal fibers. Okay, bundle of His or AV bundle. This is also called bundle of His. And then it divides into right and left branches and go to the wall of the ventricles and give branches called the Purkinje fibers. Okay. Cardiac muscle contraction. When the cardiac muscle fibers inside the muscle fibers are also called the muscle cells. So remember the same thing, not different. When the muscle fibers or muscle cells inside the muscle contract, all of them together, the cardiac muscle, whole muscle contracts, right? That makes sense. Okay, now the contraction of the heart muscle is different than the contraction of the skeletal muscles. Those are the muscles, skeletal muscles, we use to move our body parts attached to the bones. So skeletal muscle contraction is different than the cardiac muscle or heart muscle contraction. In case of skeletal muscle, the contraction is very fast. So if you see the action potential, it is very steep, goes very sharp rise and sharp down. Okay, so the duration is very short, contraction is fast. And if you see the cardiac muscle, you will see that the cardiac muscle contraction takes longer time, slower, then goes down like this. So you see the duration is more. This is the time. So skeletal muscle is first contraction, cardiac muscle takes longer to finish its contraction because blood must get out or from the chamber, so it should take some time. So the contraction of both skeletal muscle and cardiac muscle is helped by some ions. Calcium is one important ion that is required for muscle contraction. In ANP1 you have learned the calcium, actin, myosin, troponin, tropomyosin, how the calcium binds with troponin before muscle contraction. So calcium is very important. Okay, So the action potential in the skeletal muscle is pretty fast. You see that sharp rise, sharp drop, okay, compared to the cardiac muscle. In case of cardiac muscle, it is long, the duration, and calcium ion enters the ions enter the cell over prolonged period, so slowly enter, and contraction period is long, around about 250 milliseconds. Now here you see that I showed you in previous picture. This is cardiac, right? So this is cardiac muscle contraction, this is skeletal. So you can see that this cardiac muscle contraction has been shown here, the action potential, okay? So here is the sharp rise that I mentioned, and then this part is called plateau. That means not much change. You see it stays same, not going up or down. And this part is also slowly going down. So this part is called depolarization. This part is called repolarization. So in between the depolarization and repolarization, you have this plateau. Okay, so this gives more time before the relaxation of the heart muscle. Depolarization, remember, this is important. Depolarization, why it is important? Because depolarization causes contraction. Okay, so very important, right? When depolarization occurs in the heart muscle contracts. Repolarization causes relaxation. After contraction, you know that heart muscle relaxes. Then again contracts, right? However, after contraction is completed, then there is a pause before relaxation, just to make sure that enough blood gets out. Otherwise, if immediately after contraction relaxation occurs, then some blood will not be able to get out. So after contraction of the chamber, the time is some time interval is given by the plateau before the muscle starts to relax. So during this time, the blood, enough blood can get out from the heart, can go to the body or to the lung. Makes sense, right? So you see depolarization, and this one is showing the contraction, then delay, then relaxation. Okay, so depolarization causes contraction, repolarization causes relaxation. Okay, and the total time is about, here you see 250 millisecond. Now the question is, why the depolarization is first and then plateau, then repolarization, like this. If you see here, the depolarization is pretty fast, not as fast as the skeletal muscle, but it is pretty fast. Why? Because this depolarization occurs due to the entrance of sodium, and the sodium channels are first sodium channels, voltage gated first sodium channels. Okay, so what is that? This is, for example, a cardiac muscle fiber or cell nucleus. This is another cardiac muscle fiber or cell, and you have the channels in the cell membrane. You know that cell membrane has ion channels, right? So these channels, in case of cardiac muscle membrane, are sodium channels. But what kind of sodium channels? There are different types of sodium channels. First, sodium channels, slow sodium channels. In the cardiac muscle fibers, these channels are fast. Why? Because they are voltage gated. And when the electrical signal, you remember the conductive system produces and transmits electrical signal. When that electrical signal arrives, what kind of signal? Electrical arrives, the voltage gated sodium channels get opened. Opens the sodium channels, and these channels open abruptly, not slowly, suddenly, all together. So what will happen? A lot of sodium outside of the cell, always sodium is high than inside. So when these channels will get opened suddenly, a lot of sodium ion will get in. Make sense? And that sodium is positively charged, positive ion, right? So when sodium enters into the heart muscle cell, if I record the activity inside the cell, if this is before the signal arrived, this is called the resting membrane potential, before the signal arrived. Okay, and when the signal arrives, the sodium channel suddenly opens, sodium get in. Now if I draw this way, upwards positive and downwards negative, and measure the voltage inside the cell, sodium got in, a lot of sodium suddenly, right? So inside the cardiac muscle cell or fiber will become positive suddenly. So that causes sudden depolarization, because this way is positive, right, upwards. So I'm seeing the change inside the cell. And then what will happen? So this is due to sodium influx, sudden, that's why it is sharp. And then what happens next? The sodium channels get closed here, so it will not anymore, it will not go upwards. Then here potassium channels start to get open, as well as calcium ion channels. So potassium and calcium, let's say these are potassium channels and calcium channels. So potassium positive 2, calcium positive 2. So remember, when potassium channels get opened, potassium gets out, opposite of sodium, because potassium is always high inside, so the ions will move from high to low, so we'll get out. Now you see, positive potassium is getting out. At the same time, calcium will open, calcium channels will open. So calcium is positive, will get in. So you see now sodium channels are closed, so no more sodium is getting in. But what is happening in second phase? Potassium is getting out, that means positive is getting out, and calcium is getting in. So some positive is getting out, some positive is getting in. So that will keep the potential kind of same, unchanged, because one is getting out, potassium out, and calcium in, and both are positive, right? So we will not make much change inside the cell. And then calcium will get closed here. So calcium closed, but more potassium will be opened. So now calcium is closed, no calcium is getting in, but more potassium is opened. So potassium will continue to get out more. So if only potassium positive gets out, inside the cell will move towards less positive, right? Because potassium is getting out, so we'll move down. That is the repolarization. So potassium out, or efflux. So now you see depolarization. This one is depolarization. This is caused by sodium influx, sudden voltage gated fast acting sodium channels, and then sodium gets closed here, but potassium and calcium both get opened, and that is the plateau. Okay, so 2, and then 3. Calcium gets closed, but more potassium opens. So potassium gets out and causes repolarization due to efflux of potassium. Make sense? So this part is very important because it gives some time between contraction and relaxation. So that makes sure that blood can get out. And this is the plateau that I showed you here. So if I ask you, plateau occurs due to what? Opening of both potassium and calcium simultaneously. So everybody, you remember that the plateau that occurs in the heart muscle during the heart muscle contraction between the contraction and relaxation, right? So this allows some time um, to let the blood, enough blood gets out. So here, if I want to see the cause of depolarization, plateau and depolarization, this is a cardiac muscle cell or cardiac muscle fiber, same thing. Cell or fiber, same thing. Okay, and this is another cardiac muscle cell or fiber, and in the wall of the cell membrane, in case of cardiac muscle, you have fast acting sodium channels. So I'm showing the sodium channels or doors. However, these sodium channels are what? Fast acting voltage gated sodium channel. You see here, voltage gated fast sodium channels. That means they open abruptly, suddenly, when the signal arrives. Which signal? You remember a few minutes ago I mentioned that the conductive system, as you know, produces the impulse. What kind of impulse? Electrical impulse, right? So when that impulse or signal, electrical signal, arrives in the muscle, the sodium channels will get opened. Now Now remember, sodium concentration is always high outside. So when sodium channels abruptly or suddenly open, sodium will rush in, will get in suddenly, right? Plenty of sodium. So that will cause what? Sudden rise of depolarization. Now before the signal arrives, this is the status inside the cardiac muscle cell. That is called the resting membrane potential. In resting condition, no signal arrived yet, okay? No change in the heart muscle. And this way, if we draw positive and this way negative, then let's see what happens, okay? I'm measuring the voltage inside. So remember, the voltage inside I'm looking at. So when the electrical signal arrives, the sodium channels suddenly open. Why suddenly? Because they are voltage gated, fast acting. There are some sodium channels, those are slow, but these are fast. Okay, so a lot of sodium will get into the muscle cell or fiber. So now I'm measuring inside. So if sodium, which is positive, gets in, it will move towards positive, right? So sudden move towards positive due to what? Sodium influx entrance, and this is called depolarization that I mentioned before. And then what happens next? The calcium channels, sodium channels start to get closed, but calcium channels start to get open. So let me draw the calcium channels. So these are the calcium channels, okay? And calcium is also positive, right? So when calcium channels will get opened, remember, calcium will get in, right? And some sodium will be pushed out. So you see, calcium is getting in, that means positive ion is getting it in, but some positive sodium is getting out. So the membrane potential will not change much, will stay like that. That is called the plateau that I mentioned. Okay, and then the potassium channels will get opened. Calcium will get closed, sodium got closed already, so potassium channels will get opened. Remember, potassium is always high inside, so when the channels will get open, the potassium will get out, not in. And potassium is also positive, so positive potassium only is getting out, so it will move towards less positive, because from inside the potassium is getting out, so positive is getting out, and we are measuring all the time inside the cell. So the voltage will move towards negative, that means less positive, and that is due to potassium efflux or exit, efflux or exit. Okay, and that is the repolarization. So depolarization, plateau, depolarization. That's how the cardiac muscle action potential takes place. Okay, so now the cardiac muscle has some important physiological properties. What are the properties? Let me mention those. One is called autorhythmicity. Auto means self, and rhythmic means contraction in regular interval, right? We know that heart beats in regular interval, not like fast and then slow, then fast. No, always maintains the interval. Like this is one beat, then interval, another beat, then another beat, then another beat, right? So that interval is maintained between the contraction. That is the autorhythmicity. And who does it? The conductive system. As a node, you must remember 70 to 80 times in normal resting condition, but in rhythmic way, it produces electrical impulse. So the contraction will be rhythmic. And it happens throughout the life, 24 hours, even when you are sleeping, right? So it is auto, self. You are not telling it to do it. Number two, another important property of cardiac muscle is the syncytium. I already explained it in last lecture. Syncytium means whole unit. You remember that all cells are connected by gap junctions and attached by desmosomes. So the muscle fibers work together as an unit. That is due to gap junctions and desmosomes, those intercellular junctions. We talked about that. And then refractory period. This is what I am going to explain now. Refractory period, or RP. What is refractory period? RP. During the contraction of your heart or heart muscle, like your heart muscle is contracting, during the contraction, if you give any stimulus, another stimulus, then heart muscle will ignore, will continue contraction, which is very important, because if your heart, when it is contracting, if a signal comes from somewhere else in your body, from your body, then heart muscle should ignore it, should not listen to it, because if it listens to it and it stops contraction, then your blood will not get out, brain will not get the blood, right? Body will not get the blood. So heart, during its contraction, like heart is contracting, if any stimulus or any signal arrives from somewhere else, heart will ignore it. And that is the refractory period. During the time, heart does not listen to any other signal. Okay, during its contraction, that is the refractory period. Now, refractory period could be two types. First, about 200 millisecond is see here, 0 to 200 millisecond. This part is the blue part is called the absolute refractory period, and the end part, only about 50 millisecond, is called the relative refractory period. Why this part is called the absolute refractory period? During this contraction of the heart muscle, if signal comes, whatever the strength of that signal is, even if it is very strong, heart will completely, absolutely not listen to it. That's why it is absolute refractory period, totally ignore. And near the end of the contraction, if signal is strong, heart may respond to that. If it is weak, heart may ignore. So it is not absolute, it is relative. Depending on the strength of the signal or type of the signal, heart may listen. Now, only last 50 millisecond is relative refractory period. That means heart may listen to another signal and stop further contraction, which is not harmful, because you see, first 200 millisecond it is not listening to anything, so it is almost, its contraction is done. So only last 50 millisecond is not that important, because more than 80% blood will get out during this absolute refractory period. So heart will not listen to anything else during this time. We finish its contraction, so 80% or more blood is already out. So then if it listens, it is not a big problem. So this is a very important protection for heart. Otherwise, if heart listens to outside signals, it will not be able to finish its function. Okay, so those are some important properties. Another important property is elasticity. These are physiological or functional properties. Elasticity means heart muscle can be stretched. If you pull the heart muscle, it will get longer, and when you will remove that pressure, it will go back to its actual shape. So that stretching property of the heart muscle is called the elasticity. The elastic things you use in your clothes, you can make it longer, right, by pulling it from both ends, and when you release the pressure, it goes back to its actual shape. So that is the elasticity. So the relationship between the pressure and length is length of the muscle is proportionate to the pressure. Okay, more pressure, more length. Makes sense? And this must be within the physiological limit, within a limit. If you do too much, then the elasticity will be lost. Just think simple in your clothes. If you use the same cloth when you are skinny, now you are much bigger in size, but if you continue using that cloth that has elastic thing, it eventually will get lose its elasticity, right? Same thing here. If you continuously put too much pressure on the heart muscle, then eventually it may lose its elasticity, and this law will not be followed anymore. So that's why it is said that within the limit, if you put pressure, the length will increase, and also when you remove the pressure, it will recoil. And this law is called Frank-Starling law. Starling's law. However, this law will not work if the elasticity is lost. Okay, and that is called heart failure. When the elasticity of cardiac muscle is lost, then the heart will stay where? The muscle will stay relaxed, will not recoil, heart will be big. So that is the indication of the loss of elasticity, and that is called heart failure. So in heart failure, you will see the size of the heart is bigger, always stays big. It cannot contract or recoil forcefully. So blood cannot get out, enough blood cannot get out. That is the heart failure, loss of elasticity. Okay, we talked about the pacemaker potential as a node. Now, you see the SA node produces electrical impulse, right? SA node. It is called the pacemaker, and the SA node cells are different, special type of cardiac muscle cells. You remember in the conductive system. So the cells or fibers in the SA node are different than the cardiac muscle. So the action potential is also different. In case of cardiac muscle, you remember the action potential is like this. There is a plateau like this, right? We explained that. However, in case of the cells in the SA node, if you see, the action potential is not like cardiac muscle fibers, but like this. You see the picture above. First part is slow rise, then sharp rise, then sharp down, then slow first rise, then we'll go faster, and like this. So the action potential in the SA node or pacemaker cells is different than cardiac muscle cell. So no plateau, right? No plateau here. And you see here one thing is important. This part, the first part as I mentioned, is slow rise, okay? And then it goes up when it reaches the threshold, it goes up fast. So this part is called, again, you see after repolarization, when again depolarization starts, first part is slow. Again, first part is slow. So each action potential is one heartbeat, right? So SA node produces 70 to 80 action potentials per minute in normal resting condition. Average is 75 beat per minute, right? And this part is called the pacemaker potential. And we know that depolarization occurs due to sodium influx, same in this case too, no plateau, so no calcium is working here, and repolarization is due to potassium efflux, right? So influx, and this is outflux or efflux, okay? And then when the depolarization starts, what happens, you see, again sodium starts to get in, but here there are some leak channels. Leak channels stay open during this time. So that means what you see, this is a cell in the SA node. Sodium is in the first part of depolarization, sodium is getting in, but through some leak channels, small amount of sodium is leaking, getting out, okay? So more sodium is getting in, so it will move towards positive, but since some is leaking out, like in a container, if there is a leak, if you put water, then some water will get out, right? So the filling will be slow than the intact one. So same way, this part, during this time only, during this time, the leak channels stay open. That's why it goes up slowly, which is very important. You see that this slow rise is very important because this is one beat, right? And this is another beat. In between two beats, you need some time. We know that that is the rhythmic contraction, right? One beat is done, then interval, then another beat. That interval between the beats is given by this slow rise. So contraction will not occur until this part happens, okay? So this is the interval. This is the interval. So the interval is maintained by this slow rise of depolarization in the first part of the action potential. The whole thing is the action potential. This is the first part of depolarization of the action potential, right? Will be slow. Now, if I can make it faster, what will happen? You see, if I make it faster, close that leak channel, then what will happen? Next beat will be faster. The interval will be short. Interval will be short, right? And if I can make it longer, this part, then the interval between the beat will be longer, right? So by changing this pacemaker potential part, this slow rise first part, we can make the heart rate faster or slower. If we can make this faster, then heart beat will be faster. If we delay this one, then it will be slower, like this. This is one beat, then next one, if I make it sharp rise, then will be I'll get more action potentials, more heartbeat. Now if I can delay here, this is the first one, then slow rise, second one, slow rise, third one, slow rise, fourth one, right? So you see the heart rate will be slower. Now if I can make it faster, then it will be more heart rate. And we have the medicine that can work here to increase or decrease the heart rate. For example, the hormone chemical adrenaline that is secreted when you get scared or excited, that makes this faster, so heartbeat will be more. And another chemical that is called acetylcholine or ACH, that will prolong this, so the interval will be longer, heart rate will be slow. Okay, so here you see parasympathetic stimulation. When you are relaxing, ACH will be released and that will prolong this, so the heart rate will be slower. Interval will be longer between the beats. Make sense? So slow depolarization. And sympathetic stimulation releases adrenaline, and that will do just the opposite, will make this part faster, so next beat will be here, right? And interval will be short. Here you can see this is short, so more heartbeat in same amount of time. The heart rate, if the heart rate is irregular or heartbeat is irregular, in common term we say arrhythmia. Okay, and arrhythmia indicates any irregular heartbeat, but irregular could be different types, right? If the heart rate is slower than the normal heart rate, that is called bradycardia. Heart rate or heartbeat. Tachy means fast. So tachycardia, cardia heart, if the heart rate is fast, more than 100, it is called tachycardia. And less than 60 will be considered as bradycardia. Okay, and here you can see this is slow, bradycardia, the interval is long, right? And this is normal, and this is tachycardia, more heartbeat, interval is shorter. Okay, now how the heart function is regulated. When we say heart function, two things must be controlled. One is the force of contraction, and another is heart rate or heartbeat. So force of contraction and heart rate, these two things are regulated, should be regulated, right? If force of contraction is more powerful, then more blood will get out, that is cardiac output will be more, and blood pressure will be more, because more blood is going to the artery, pressure will be higher, right? If the force of contraction is weak, then cardiac output will be less, blood pressure will be low. So just opposite. Heart rate is also, if the heart rate is more, usually we see the blood pressure is more. Then how these two things are controlled? These two functions are controlled. When we say function, we indicate mainly these two things. So in your brainstem, you have the cardiac centers. You see here the cardiac center. These are the cardiac centers. Where in the brainstem. Brainstem has pons, medulla oblongata, you must remember. So in the medulla oblongata part, if you remember in P1, you have seen the brainstem. This is the pons, kind of round, right? And this is the medulla oblongata, then the spinal cord. So in the medulla oblongata, you have the cardiac centers, okay? And two types of centers, cardio acceleratory center shown by the red color here, and cardio inhibitory. The name is telling you. One will accelerate, work as an accelerator of your car, it will make it faster. Another is inhibitor, like brake of your car, will slow down, right? So you have both acceleratory as well as inhibitory centers in the medulla oblongata. And the signal from those centers go to the conductive system. You see here the SA node here, AV node here, and they regulate, mainly the SA node in normal condition is the pacemaker, regulates the force of contraction and heartbeat. You remember that, right? So when the accelerator center is activated, signal goes through the sympathetic nerve here to the SA node as well as to the wall of the heart muscle. And sympathetic, remember, would increase the heart rate, increase the force of contraction, okay? And parasympathetic will do the opposite. Signal will come from cardio inhibitory center, you see cardio inhibitory center, and through the parasympathetic or vagus nerve. Vagus is parasympathetic, okay, and from acceleratory through the sympathetic. So red one is showing sympathetic and yellow is showing parasympathetic, okay? And sympathetic, you see, from acceleratory center will go down to the spinal cord and will be relayed here, and from the spinal cord will go to the ganglion called sympathetic ganglion, this one, round structure, and from there will go to the heart. So that's why you see the ganglion, and before the ganglion, these fibers are called preganglionic, and this is post after ganglion. So sympathetic releases adrenaline that I mentioned before to stimulate the heart, force of contraction and rate. Parasympathetic releases ACH, acetylcholine, will inhibit. Okay, the main parasympathetic nerve is the vagus that goes to the heart. So acceleratory center will send signal through the sympathetic nerves and inhibitory through the parasympathetic nerves. Okay, and we will do opposite. One will work as the accelerator in your car to make the car faster, another like a brake to inhibit. Okay. Factors affecting the heart rate. Multiple factors can change the heart rate. A few are explained here or shown here. One is by the autonomic nervous system. When you get scared, right? You don't do it. When you get scared, your heart rate increases. So that is autonomic. It happens by itself. When you do exercise, sympathetic stimulation takes place, and that will increase the heart rate and increase the force of contraction. That means blood pressure as well, cardiac output. And when you are relaxing, your parasympathetic works that I mentioned will slow down, decrease the blood pressure. And So both sympathetic and parasympathetic belongs to the autonomic that I explained in last slide. Both sympathetic and parasympathetic, and they happen by themselves. Hormones. There are many hormones that can increase or decrease the heart rate. The main one I mentioned, adrenaline, increases and acetylcholine decreases. Adrenaline is also called epinephrine, same thing. Okay. Thyroid hormone, thyroxine, increases the heart rate. So if someone has hyperthyroidism, more thyroid hormone, thyroxine, is released, so the heart rate gets faster in hyperthyroidism. Okay. Body temperature increases. Increased body temperature increases heart rate. Okay. Exercise increases the heart rate because your body needs more blood, muscles need more blood supply, so heart rate will be more, as well as the cardiac output or force of contraction. Electrocardiogram. Electrocardiogram is the electrical signal that is produced by the conductive system, you remember, and when the conductive system produces the electrical signal, it spreads everywhere in the heart. However, since it is electrical signal, it also goes everywhere to your body. So not only the heart, your whole body gets electrical signal. So you can pick up now, if this is your body, you can pick up the signal from anywhere of your body. So that's why you know that electrical signal spreads quickly everywhere, right? So everywhere in your body some signal will go, and you can pick up that signal from by putting electrodes anywhere in your body. Usually we put the electrodes either around the heart, chest electrodes. Some of you have probably seen, we put several leads or electrodes around the heart to pick up the signal from the surface of the body, chest. Sometimes we put limb leads or electrodes, hands, to the upper limbs and lower limbs, right, and pick the signal. So you can pick the signal from anywhere because it is electrical signal generated by the conductive system of the heart, and that is called EKG, electrocardiogram, that recording. Okay, or ECG in some countries. Most of the countries they use that term ECG. Here we use EKG. Okay, now if you see that EKG tracing recording, you will see the waves. So here you see first wave is called the P wave. The second one is very long, very big. This is called QRS complex. Because two waves are actually forming this QRS. I will mention that in few minutes. So QRS complex, and then the last one is T wave. So these are three components. Okay, P wave, QRS complex, and T wave. These are three components of EKG. And this way is the time, T, time, and this is the amplitude. This indicates the force of contraction. Okay, so we can measure both from the EKG, and we actually know how much time the P wave should take, how much time the QRS should take in normal heart function, how much time the T wave should take, what should be the duration of these, right? Also between P and QRS, the time interval, between QRS and T, the interval. So we measure all these intervals, and we know what is the normal range of those intervals and compare with the patient's interval to see if anything is wrong during the timing, as well as we measure the amplitude, the height, to see the force of contraction, if it is weak or strong. Okay. Now, P wave. Why this wave is produced? P wave is produced by the contraction of atrium, atrial depolarization, or atrial contraction. Depolarization causes contraction, right? We know that. QRS, here two things happen. After atrial contraction, atrial relaxation occurs here, but at the same time, ventricle contracts. And ventricular contraction is much stronger, you know that, because ventricle sends the blood to the body, right, than the atrial contraction. So this QRS is, almost the whole QRS is given by the ventricular contraction. So atrial relaxation is very weak and buried because both happen at the same time. So you won't see this one, right? So QRS complex is mainly ventricular contraction. That's why it is so big, forceful. We know that ventricle contracts very forcefully compared to the atrium. And then ventricular relaxation. This is ventricular relaxation. After ventricular contraction, we have ventricular relaxation. So those are three things. So we cannot see the atrial relaxation, which is buried under the large ventricular contraction. Okay, because the atrial relaxation after this contraction and ventricular contraction both happen at the same time. Okay, so that's why we need to record the EKG to measure the intervals and the amplitude, the force. Now, if you see this interval, that is atrial contraction, right? So this interval is telling you that how much time the atria took to finish contraction. Now, if you see someone's, this part is very long, duration is longer, that means this person's atria are taking longer time than normal. So something is wrong, right? There. Same way, if we see this one is longer than normal, QRS, then we'll say that ventricle took longer to finish its contraction, which might be a problem. And if I see this one is short amplitude, then this indicates the ventricular contraction is weaker than normal. Makes sense? So ventricle might have some problem, but that's why it cannot contract forcefully. So it's a very helpful, right? Useful recording electrocardiogram. Okay, so you see those. You see here. Okay, few clinical conditions. One is, we have learned already few: tachycardia, irregular heartbeat, right? And fast heartbeat is tachycardia, slow is bradycardia, irregular heartbeat is arrhythmia, right? Now, there is another condition, clinical condition, that is called premature atrial contraction, and often occurs in healthy people, so it won't really bother, because atria don't send blood to the body, just to the same size ventricle, right? So if weak, like during atrial contraction, another weak premature contraction occurs in the atrial wall, it won't really cause any problem. Blood still will go to the ventricle. Okay, and the factors that can cause that, the person even won't know that happened. If you only record the EKG during the atrial contraction, this is the P wave, right? You might see a tiny extra bump here or extra contraction here before the main one. The weak, that is not enough to do anything premature. Paroxysmal atrial tachycardia, it's a premature atrial contraction that triggers flurry of atrial activity. Okay, and ventricle is working fine. So in that case, the heart rate may increase, could be very fast. Here you see the contraction, heartbeat, then this part tachycardia pretty fast. This is normal, and this is premature atrial contraction. Here you see this is P, right? Normal atrial contraction, but before that another contraction before the actual one. So it's a premature atrial contraction. And tachycardia, of course, you know that first heartbeat. Atrial fibrillation. This is one clinical condition. Fibrillation means high frequency, very fast, high frequency, that means very fast, irregular, chaotic, contraction. Okay, it could go like your heart will not finish its contraction, will beat like incomplete and go to next one, like shaking or vibrating, that kind of. You'll see the heart wall is like vibrating, not really forcefully finishing its contraction, just weak contraction but very fast and irregular. So if you see normal heartbeat, this is normal, right? In fibrillation, you'll see that one is strong, another is weak, then many weak contractions, irregular, sometimes fast, then slow, then fast again, but all these are very weak contractions, okay, and very fast, chaotic. And if the fibrillation occurs in the ventricle, not atrium, that becomes more concern, okay. Atrial fibrillation is not a big problem because about 70% of blood goes from the atrium to the ventricle passively and doesn't need forceful contraction. Ectopic pacemaker or ectopic contraction. We use this term to indicate this is your heart, normal heart is beating, and if you see during the contraction of, for example, your ventricle is contracting, another weak contraction occurs. So this is P, this is Q or S, and you might see an extra beat. That is the ectopic. Anywhere it can happen, an extra immature beat. That is ectopic. Normally, SC node produces these electrical impulses, right? But if heart muscle sometimes can produce electrical impulse, it would be very weak, but that can happen and that can cause a weak local contraction. Very focal or local contraction, not the whole chamber. We see ventricular fibrillation. This is dangerous because you see very chaotic, irregular, noisy contraction. Blood pressure. Blood pressure is the lateral pressure given by the blood. That's why it is called blood pressure. Who gives this pressure? Blood. And this pressure on the wall of the artery. So blood pressure is the lateral pressure given by the blood on the arterial wall while the blood passes through it. So blood passes through this artery, and when the blood is passing, pressure falls on the wall of the artery. And this is lateral pressure. You see, this is the actual pressure. Blood moves this way, right? This is the main pressure or force is moving the blood. But also lateral pressure goes to the wall of the heart. So these are showing the lateral pressure on the wall of the artery, and we measure this pressure. Okay. Now, blood pressure could be 4 different types. 2 are direct measurements. One is called the systolic. Systolic means contraction. So during ventricular contraction, the pressure is called systolic pressure. So during ventricular contraction, blood goes to the arteries and pressure goes up. So systolic pressure is high. The higher pressure we measure. We measure 2 pressures, right? The higher one is systolic and diastolic. Diastole means relaxation. During the relaxation of the heart. Now you see the pressure, diastolic pressure is the lower one, less. Why? Systole is the contraction. So this is your heart. When heart contracts, systole, most of the blood will enter into the artery, right? So now if I measure the pressure on the arterial wall, it will be higher, right? And when the heart relaxes, that is the diastole, what happens? Most of the blood gets back into the heart. So inside the artery you have less blood, so the pressure will go down. Okay, that's why we get 2 pressures. Now from these 2 pressures we can measure other 2 pressures. One is called the pulse pressure, which is systolic minus diastolic. So if your systolic is 120, diastolic is 80, then your pulse pressure will be 40. Makes sense? Millimeter of mercury. And mean arterial pressure, or MAP, here is measured by diastolic plus 1/3 of pulse. So here diastolic is 80, systolic is 120, so diastolic is 80 plus 1/3 of pulse, that means 40 divided by 3, we can say that 13.3, right? So your MAP will be 93.3. MAP or mean arterial pressure should be above 80 millimeter of mercury. Less than 80 is not good. Okay, that means your organs are not getting enough blood if MAP goes below 80. Now 3 factors directly affect the blood pressure, arterial blood pressure. There are many factors that can change the blood pressure, but these 3 are directly influencing the blood pressure. One is the volume. If blood volume is more, pressure will be more, because you remember I said how much more blood is inside the artery, that is giving the blood pressure. Okay, so more blood volume, more blood pressure. Okay, force of contraction. If the ventricle contracts more forcefully, then the blood pressure will go up, because more blood will get out. Cardiac output will be more, right? So output of blood will be more. Peripheral resistance. This is not related to the heart. These 2 are related to the heart, but this one is related to the wall of the artery, or arterial wall. You remember before I mentioned, sometimes fat can accumulate inside the artery and can narrow the artery, and that is called atherosclerosis. Also, as we get older, the elasticity of the arterial wall is lost, and the wall will get stiff and hard, and that will also narrow the lumen or artery because the elasticity is gone, so it will not be able to dilate. Makes sense? So in both cases, the blood pressure will go up if the arterial, the artery gets narrow or constricted, then blood pressure will go up. That is called the peripheral resistance. The narrowing of the arterial wall will increase the peripheral resistance, will increase the blood pressure. Increase the blood pressure. Okay. Cardiac output is in 1 minute how much blood is going to the body, getting out from the heart in 1 minute. So that is the cardiac output. However, in one stroke or contraction, how much gets out, that is the stroke volume. So 1 minute is cardiac output, and one stroke or one beat, it is called the stroke volume. Make sense? So in one beat, if 70 milliliter blood gets out, and in 1 minute you have, for example, 70 beats or strokes 70 times. So what will be the cardiac output? In one stroke 70 milliliter, and in 1 minute your heart is beating 70 times. That means 70 strokes in 1 minute, right? So 70 times 70 is 4900, right? 4.9 liter or 4900 milliliter, about 5 liters. About 5 liters cardiac output. So stroke volume is 70 milliliter, cardiac output will be about 5 liter. Makes sense? Heart rate times stroke volume, 70 times 70. Okay, so the cardiac output will be about 5 liters, 4.9 liter. Okay. So here you see stroke volume and heart rate, will multiply them to get the cardiac output. Okay, so we will stop here for this lecture.